Hello, everybody. I'm John Seaman, the Program Coordinator for the Keystone Center for Geriatric Care and Education. Thank you for attending today's webinar in the Geriatrics for the Practicing Professional series, which is titled, How Do I Help This Family? Managing Behaviors in Primary Care Patients with Dementia. You can submit questions anytime in the questions section of your control panel for the GoToWebinar software. However, we're going to hold off on answering questions until the end of the webinar. Please be aware that there will be an interactive question segment during the webinar. Immediately following the webinar, you'll be asked to complete an evaluation for the webinar. I'd like to introduce Dr. Joel Streim, who is a geriatric psychiatrist at the University of Pennsylvania Perelman School of Medicine, and Dr. Pam Cacchione, who is an associate professor of Geropsychiatric nursing at the University of Pennsylvania School of Nursing. Dr. Streim and Cacchione, you may go ahead.
Thank you, John. This is Joel Streim, and I'm here with my colleague, Dr. Pam Cacchione. The first part of this program is going to be a presentation on some of the principles associated with this topic, and then I'm going to turn it over to Pam to go through some clinical vignettes with you that give you a chance to practice and apply those principles. And then we'll be talking about some of the resources at the end that you can provide for patients and families in your practice. Without further ado, how do we help this family in managing behaviors in primary care? And look again at the learning objectives, which are that at the completion of this webinar, learners will be able to recognize at least 3 key factors that commonly contribute to behavioral symptoms in elderly patients with dementia, to identify non-pharmacological approaches to behavior management, to describe the limited role and risks of psychopharmacological treatment for behavioral symptoms in this population, and finally to recommend specific resources for your patients and families to help them manage with difficult behaviors at home. We're talking about behavioral changes that commonly challenge caregivers, and there are many of these that we see in patients with dementia. Today we will focus in particular on a few that include irritability, rejection of care, yelling and calling out, and other forms of agitation. So what do we need to learn as primary care providers and family caregivers? First, we need to understand how the person with dementia experiences situations, experiences their physical environment and also social interactions. And we also need to be able to recognize the specific factors that cause or contribute to behavioral changes in these patients. Once we understand those things, the interventions and management strategies that are likely to be successful become much more readily apparent to us. Now, at the heart of this is the concept of person-centered care, and by that we mean focusing on the elderly person's experience, trying to imagine being in their world and considering how things look and feel from their perspective. One of the important concepts here is to accept their reality because their subjective experience is real to them, even if it involves delusional thinking at times or confusional thinking. That doesn't mean that you actually adopt their point of view for yourself, but rather that you join them in their world without contradicting or arguing, and instead communicate that you'll help them. So what factors shape the patient's experiences? And secondly, how do those factors influence the patient's behavioral response? This is an overview of factors that can affect behavior in patients with dementia, and I'm going to go over more detailed concepts associated with each of these 6 factors, beginning with cognitive deficits and then going on to talk about unmet needs, both the physical and psychological, environmental and social irritants, medical and psychiatric conditions, and the distressing symptoms that occur along with them, such as pain or anxiety, and finally adverse effects of medications. All of these are factors that can affect behavior in those elders with dementia. So starting with the cognitive changes that we see in persons with dementia, there are deficits in multiple cognitive domains that are key diagnostic criteria in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, which came out in 2013. And you can see on the left a list of the cognitive domains that are addressed in the DSM criteria. And on the right are examples of neuropsychiatric and neurocognitive impairments that can result from deficits in those domains on the left. So, for example, when a person with dementia has difficulty or deficits in the areas of learning and memory, that may result in amnesia, which is loss of the ability to recall information, whether old information or to learn new information and retain it. That's what the term amnesia means. It's without recollection. Those problems with memory, though, which used to be a major focus in diagnosing dementias in past years, in past decades, I should say, now have been expanded so that we have much more detailed appreciation in the diagnostic criteria of deficits in language and other areas. So the patient who has deficits in language may actually develop aphasia, which refers to inability to speak, but that term is not limited to just inability to express oneself or make one's needs known, which are often difficult for patients with dementia, but also it may involve inability to understand spoken language, which may include instructions or explanations from caregivers. Then there are perceptual motor deficits that we can see, for example, deficits in visual recognition. And the term agnosia on the right refers to inability to recognize familiar faces or familiar objects or the function of those objects. So you might have a person with dementia who takes a comb and doesn't know what to do with it, and instead of running it through their hair, may swirl the water in the toilet bowl with the comb. Or they may pick up a fork and have no clue what to do with it and may drop it on the floor instead of using it to eat. Then the other perceptual motor area that may be impaired is the performance of motor activities. The brain has to tell the hands, legs, and mouth what to do. And the term for that is apraxia. That is inability to perform simple motor tasks, such as unbuttoning a button or zipping a zipper, or opening a package, or unscrewing the cap off a bottle. Then there are deficits in executive function that can occur as part of the dementia syndrome. And executive function includes many things, including awareness of needs, planning for how to meet those needs, actually initiating and executing a sequence of activities to carry out the plan, and see it to completion. The term abulia refers to lack of will or volition. So patients with dementia who are abulic have an inability to initiate an activity, even if they do recognize that it's something they need to do. They may look unmotivated. Or apathy refers to a lack of caring. So a person with apathy who has dementia may no longer care about eating or attending to their hygiene or bathing. Complex attention may also be impaired and lead to things like distractibility, and impairments in social cognition may lead to lack of insight. For example, lack of insight about the motives of a caregiver who's trying to help, or lack of insight into how that caregiver feels when they're yelling at them or trying to fight with them. Now let's look at some examples of how those cognitive impairments can actually lead to behavioral changes. So starting with amnesia, we can imagine a patient with dementia experiences no recall of their last bath. And therefore, they may end up in their behavioral response to a caregiver who's trying to get them to bathe to insist that she or he has already bathed, and they may refuse to bathe again. once we understand that they just can't recall when they last bathed, it kind of makes sense that they may refuse care. Aphasia is another area we talked about a moment ago, and here the patient's experience may be inability to understand a verbal explanation that the caregiver is about to change their soiled briefs. The behavioral response in the aphasic patient who doesn't understand the verbal explanation is that they resist care or become combative when touched. They feel confused about what this person is doing to them. Some more examples. Take agnosia. In this example, a patient's experiences inability to recognize the spouse's face. And the behavioral response may be to say, "You're not my wife," or to accuse that person of being an imposter or even an intruder. And if an intruder, the patient may be fearful and may feel they need to defend themselves and become physically aggressive. In the next example of apraxia, the patient's experience is that they can no longer open the deadbolt on the door to her house, and this patient may respond by beginning to yell and pace or banging on doors or even trying to exit in a panic. Now, those were the cognitive effects on behavior that are fairly direct, but a lot of these things relate to unmet needs that the patient may not be able to deal with because of their limited cognitive reserve. So that includes physical needs, such as we all have a need for nutrition, hydration, toileting, exercise, and rest. And when a patient with dementia can't recognize the hunger sensation and know what to do about that, they may become uncomfortable and get restless, start pacing, get agitated, or start yelling. And the same for hydration when they're thirsty, or feeling fecal or urinary urgency when they have a need to be toileted, and so on. Psychological needs may also go unmet. We all have a need to feel secure, autonomous, have some affection and a sense of self-worth, and that goes too for patients with dementia across the stages. And patients who are not feeling secure in their environment may get concerned or fearful or agitated. Patients who may recall their old roles, say the mother of the 5-year-old who wants to prepare a snack for her child who she thinks is coming home at 3 p.m. after school, isn't going to respond well if you tell her, no, your daughter is now 40 years old and has 3 kids of her own and lives in California, not in Pennsylvania, and may need to have someone appreciate her need to feel worthwhile as she did in her former role. So we need to pay attention to physical and psychological needs. And then there are environmental irritants that can lead to behavioral disturbances. Physical irritants such as noise, confusing visual stimuli in the environment, an uncomfortable temperature, or just unfamiliar surroundings. Then there are social irritants that mostly involve things like changes in usual or familiar routines, and some social interactions can actually become overwhelming or upsetting for persons with dementia. There are a host of adverse drug effects that can cause behavioral disturbances in elders with dementia. Some of them are just nuisance symptoms, such as mild nausea or headache from a medication, but when a patient doesn't understand that's what's causing their headache or nausea and that there are things they can do to ameliorate that and it's not going to kill them, they may become very distressed and agitated. Then there are anticholinergic effects of drugs that may further impede cognitive function, sometimes even causing delirium superimposed on dementia, and antihistaminic effects, which can be sedating and can also cause confusion. Both anticholinergic and antihistaminic effects of drugs can be associated with paradoxical excitation or even disinhibition, leading to behavioral problems. And then, of course, there are drugs that have intoxication or withdrawal states associated. And finally, akathisia is a syndrome of motor restlessness that may be caused by drugs in some cases, particularly drugs that bind to dopamine receptors and are antagonistic or block dopamine receptors, that can lead to this syndrome, which we see not uncommonly with antipsychotic drugs, but also with non-psychotropic drugs such as metoclopramide or drugs that we use to treat gastroparesis and diabetes. Those drugs have dopamine blocking effects as well and can cause akathisia. So we need to recognize these and their contribution to behavior problems. Then there are medical conditions and the associated somatic discomforts that I've listed on the right that can lead to behavioral problems. All those medical conditions on the left are fairly common among older adults. Just as an example, let's take arthritis or osteoarthritis of the knees. That patient who has some pain in their knee joints may not be able to understand what's going on. They may not know what to do about it when they have dementia, and they may start pacing to try and walk off the pain, if you will, and that just leads to more wear and tear on the knee joints, more inflammatory response, and more pain. And you may get a cycle, a vicious cycle, if you will, of increasing pain, increasing agitation, the more pain, and so forth. And we need to interrupt that vicious cycle to help manage the situation. The same sort of thing can happen with dehydration leading to constipation or any of these other conditions that I've listed, which lead to uncomfortable symptoms like urinary urgency, shortness of breath, dizziness, or fatigue. All of those can be distressing to older adults with dementia and lead to behavior problems. So can psychiatric conditions lead to behavioral disturbances, not just depression and anxiety, but sleep disturbances that cause sleep deficits are common. Substance use disorders may also be a problem for some older adults. I already mentioned delirium, which can be superimposed on dementia. And with or without delirium, patients with dementia can develop psychotic symptoms, such as delusions and hallucinations. It's often tempting to treat the delusions and hallucinations when they occur with antipsychotic drugs, but in fact, there's a limited role and numerous risks that are associated with antipsychotic drugs in older adults with dementia. Efficacy studies show that some patients with psychosis, agitation, and aggression can benefit without being harmed, but there was a large NIMH-funded trial over 10 years ago that showed that side effects limit benefits. In essence, they cancel out the benefits, and patients often can't tolerate or drop out of treatment, so that the overall effectiveness of these drugs was not demonstrated in that trial. At the same time, in the early 2000s, safety data showing a doubling of risk of stroke and death with conventional and atypical antipsychotic drugs led the FDA to issue a black box warning about those risks, and also with a reminder that no drugs are approved by the FDA to treat agitation and dementia. There are evidence-based approaches, though, to behavior management in dementia. Despite the limited effectiveness of antipsychotic and other psychotropic medications, there is some evidence that citalopram in doses up to 30 milligrams a day can reduce irritability and agitation. And those were data that were from another NIH-funded trial. However, beyond medications, there's expanding evidence for the effectiveness of non-pharmacologic interventions, and practice guidelines for dementia care, as well as expert panel recommendations over recent years for non-pharmacologic approaches, have listed these as first-line treatments. One example of such an evidence-based approach to assess and manage behavior is the DICE approach, which was promoted by Helen Kales and colleagues. The DICE acronym stands for Describe Specific Behaviors in the Context in which they occur, followed by an investigation of the patient, environmental, and caregiver factors that lead to behaviors or aggravate behaviors, and then the creation of a treatment plan with interventions that can address those patient, environmental, and caregiver factors that are discovered during that investigation or assessment. And finally, as with all interventions, we need to evaluate the effectiveness of our interventions, including any adverse effects of medications that are used. So behavior treatment planning needs to focus on managing all the contributing factors that we've discussed so far, addressing unmet physical and psychological needs, modifying those environmental irritants or their sources, treating the medical and psychiatric conditions as well as the distressing symptoms that go along with them. And perhaps one of the important things that's often overlooked is the need to educate caregivers to use effective communication and interpersonal strategies. So that brings us around full circle to the concept of patient-centered care again, and the question of what it is we should be teaching our family caregivers. First, we should teach them to look for meaning in verbal and nonverbal communication. If the patient can understand language, ask, what do you want? How can I help? And when language comprehension and communication becomes severely impaired, then look and listen for the nonverbal clues to sources of distress or unmet needs. It's important to avoid saying no, avoid arguing or disagreeing. If you start with that kind of a response to a behavior, the patient will no doubt see the caregiver as the adversary, as the enemy. However, if we start by offering help in ways that reduce distress or meet needs, asking what do you want, how can I help, and do the care without compromising safety, the patient will usually see us as advocates rather than adversaries. So I'm going to next move on from the principles that we've been discussing and turn this over to Pam to present the clinical vignettes. And this is the part where we're going to ask you to think about cases and respond to some interactive questions. So Pam.
Thank you. So welcome everyone. I'm going to start with clinical vignette number 1. This is a story of a 76-year-old woman who brings her 79-year-old husband for an office visit. He's currently treated with hydrochlorothiazide for hypertension and naproxen as needed for osteoarthritis of his knees. And he was diagnosed with dementia due to probable Alzheimer's disease over a year ago. For many months after the dementia diagnosis, he had been awakening frequently in the middle of the night, wandering around the house for an hour, going to the bathroom, then quietly returning to bed on his own. However, over the past few weeks, he's been packing his suitcase around 3 a.m., declaring, "I'm going home now." Each time, his wife tells him that he is home, but he yells, "I have to go. You can't stop me." When he refuses to return to bed and starts pacing around the house, she locks the deadbolts and stays up all night to make sure he doesn't leave. His wife is now distraught and exhausted from lack of sleep and asking for something to calm him down. So you obtain history from the patient's wife. Which of the following factors do you suspect is contributing the most to the recent change in nighttime behavior? So you may see now on your screen, please select your choice and hit submit.
As the tabulated results come in, we will share those with you and discuss the answers.
So we just give you a few seconds, and when the majority of you have responded, we will go on to discuss each one of the answers. Okay, very good. So about 80% of you have responded. So about 18% of you responded to agnosia as a possible cause. And that's really good. You get that from a clue from the vignette that he doesn't recognize that he's actually at home. So that's really helpful that that you identified that he really wasn't aware that he was at home at that particular time. And another 36% of you talked about low daytime activity with frequent naps. That could be a possibility and could contribute to suggest an increased physical activity during the day does improve sleep. His suitcase is kept in his bedroom by his bedroom dresser, about 11% of you. Well, this could be a visual trigger. If he really recognized that he was home and felt secure, he really wouldn't be looking for the suitcase, but that is a possibility. And he could have had a medication effect from the hydrochlorothiazide and the naproxen. If he was taking the naproxen, it causes fluid retention, and then you have the hydrochlorothiazide. He could have had a diuretic effect at nighttime. So you would want to check to see what time he was taking those medications and see if that might be influencing it. And then pain is always a possibility with someone who has osteoarthritis of the knees. So thank you. Very great, very good job, everyone. Joel, do you have anything you would like to add?
Yeah, I think that you can see from the distribution of these answers that all of these things are relevant to think about in a case like this. And many of them are actionable. That is, they may be things for which we can think of easy remedies in some cases. I would mention, though, that in this case, agnosia probably does play a fairly large role. Whether it's the most or not, I think you can debate. But I think that the way the case was described, this is a person who really doesn't get that he's at home, and maybe just not. He's no doubt surrounded by familiar possessions and objects, and by his wife, who he may associate with home in a better cognitive state.
Right.
But these are things which may actually cause most of the agitation that he's experiencing at night. And remember, too, when people wake up in the middle of the night, they often can be more confused at that time in the 24-hour cycle. So something to keep in mind as you plan for treatment and help caregivers figure out what to do, and we'll come to that next.
Okay. Oh, I have to take my screen back. Thank you. And here we go on to the next question. So which of the following management strategies would you first suggest? Engage him in physical activities during the day, coach the wife to avoid contradicting or arguing, adjust medications, hide his suitcase so he can't pack to leave, or prescribe a sedating medication at bedtime. So if you could please again select your choice and click submit, and we'll allow you a little bit of time to respond to the questions, and then we'll come back to you and discuss each of the responses. So we're getting quite a few coming in. Thank you for responding. Great. Terrific. So for the first, we have 21% would engage in physical activities during the day. This is a good idea in the sense that evidence has shown that exercise during the day does improve sleep at night, so that would be a good intervention. One of our roles as providers is to really coach the families and help them avoid contradicting or arguing. As you saw in the case study, the wife did say, but you are home, this is your home, and that just aggravated him even more, and he became a little more agitated. So this may be the highest impact. You may have the highest impact by actually working with the family member on avoiding contradicting and arguing, but more validating and recognizing that they are feeling insecure or in an unfamiliar setting, so asking how you could potentially help. And then about 7% offered adjusting medications, and I think that's totally reasonable approach, particularly if she was giving, for some reason, the thiazide diuretic at night, or large doses of naproxen. So trying to see what might be most beneficial for the individual may also be helpful. And then only 4% would hide the suitcase so he can't pack to leave. It may help, but if he didn't feel safe and secure, it really wouldn't be an issue having the suitcase available. And then prescribing a sedating medication, I'm happy to see that none of you recommended that. Due to changes in the sleep architecture with dementia, these may do more harm than good. Melatonin in small doses may be acceptable, but on the whole, it's avoiding sedating medication in older adults with dementia is recommended. So again, Joel, do you have anything more to add to this case?
No, I would agree with all of those comments, Pam. I do think that one of the things, only 7% endorsed adjusting medications as a first-line strategy, and I think that while I would agree coaching the wife is probably the most important and perhaps the first-line thing to do here, when patients have untreated pain, as we were talking about in the lecture half, we really do need to make sure, even if they're not complaining actively of pain, that we recognize it when it is contributing to these problems. I think in this particular vignette, there wasn't any reason to think that pain was a primary driver of the behavior. But it's always good to keep in mind to look for and ask about or look for the signs of pain, even if the patient's not telling you they're in pain.
Very good. Okay, now we're going to go back to our second vignette. So a 59-year-old daughter is the caregiver for her 81-year-old mother with diabetes and dementia due to probable Alzheimer's disease. She brings her mother in for an office visit, complaining that she is incontinent and resistant to having her disposable adult briefs changed. When she tries to hold her mother down to remove her briefs and wash her, her mother looks fearful and screams, "You people are trying to kill me." The daughter has also noticed that the patient has been looking out the window and talking about a man she claims to see in the backyard, not visible to the daughter, who she believes is trying to break into their house. The daughter is asking for something to make her mother less fearful and more cooperative with care. So again, we want you to put yourself in the patient's shoes. What do you suspect she is experiencing that contributes the most to the care rejection behavior? Would it be agnosia, low vision due to cataracts or retinopathy, feeling afraid or feeling assaulted, feeling exposed or embarrassed, or hallucinations and delusions or psychotic symptoms? So please, again, select your choice and press the submit button. And we'll give you a few minutes to, a few seconds to respond to the question, and then we will discuss each of the answers. Thank all of you for responding. You seem to be coming in pretty quickly here. And we'll just wait.
So we really didn't need to play the jingle from Jeopardy.
Right. All right, thank you all. So the first, again, agnosia. I see about 10% of you responded to that one, and those of you who recognize that she is having some difficulty with the agnosia, very good. She described, "You people are trying to kill me." She's not recognizing her daughter, that her daughter's there to help her, and that she is misinterpreting what's going on around her. The low vision was actually a possibility because of the diabetes. She could have retinopathy or cataracts related to the dementia or the retinopathy or the diabetes. I would totally agree with 37% of you that she was feeling afraid or feeling assaulted. Anytime an older adult who doesn't recognize why they're being restrained or held down to be changed would be frightened, and it's clearly a possibility. And 7% of you feeling exposed or embarrassed. Clearly, if you're having being changed without your cooperation, that would be a feeling like that. And yes, she is also, almost 50% of you recognize that she is having hallucinations and delusions. So there are a few things going on here in her particular case. But the initial thing that is probably contributing to it is that she's not recognizing her daughter is there to help her. And then she also may have potentially either Lewy body dementia or be having some delirium superimposed on her dementia, or potentially new onset hallucinations related just to the dementia. So Joel, would you like to comment?
Yeah, we do see in some low vision patients, and we don't know this from the vignette, we do know she has diabetes, and given her advanced age, she may have some problems with vision. But we do need to consider in the differential diagnosis the syndrome, which sometimes occurs when people have low vision, and they can actually develop visual hallucinations from that. It's also the case that in dementia with Lewy bodies, as you said, visual hallucinations may present fairly early on in the course of that dementing illness. But in the end, I think that this is a woman whose experience of her own health, interior environment as well as the external environment, is that she's being assaulted. She's feeling afraid, and so it may be that that's the thing to keep your eye on as you're doing treatment planning, in addition to the actual hallucinations and paranoid delusions which she's expressing.
Great. So we're going to move on to the next question. So which of the following management strategies would you suggest first? Coach the daughter to identify herself before attempting care. Try to get to a comfortable place for changing briefs. Suggest the daughter change briefs while mother is standing. Low-dose quetiapine to treat hallucinations and delusions. Or refer to the patient to a psychiatrist if available. Again, if you could please select your choice and press submit. We'll wait a couple seconds and then review the responses with you. And we don't have any that are all of the above. Okay, it looks like a lot of the responses are coming in, so we'll start with the first one of coach the daughter to identify herself before attempting care. This is critical. I totally agree. You want to decrease aggression on both sides. So if the member can recognize, or the patient can recognize that it is her daughter, and the daughter is not holding her down, that's the other thing we would probably coach the daughter on, is to not restrain her mother while trying to provide care that is very threatening. So you don't quiz or force. And if the patient gets initially agitated by the attempt of care, you can actually walk away and try again later. And you don't necessarily have to do it right at that instant. And then about 11% of you are trying to get her to a comfortable place for changing the briefs. I think this is not a bad idea, particularly if you can bring her to a location that has other visual cues that this is a place where you are toileted or changed. Like if you were to bring her into the bathroom and set her on the toilet, so maybe she would actually be able to urinate again or move her bowels. This might be very helpful. What might also help with that is there is contrast associated with the bathroom setting. A white bathroom with a white toilet with a white sink isn't very differentiating and may cause difficulty for an older adult to determine where the toilet is, where the sink is. So having contrasting colors behind the toilet may be helpful for that as well. And then I suggest the daughter change the briefs with the mother standing. None of you suggested that, and I think that's reasonable not to. I think it increases the risk for falls in older adults for this. And then about 11% of you would treat with low-dose quetiapine to treat the hallucinations and delusions. You know, ideally, if these are threatening to her and she does not feel safe, that may be an option. I would suggest initially trying some of these other things first before we did that, but there may be a place for that in this particular case. And then referring the patient to a psychiatrist if available. Joel and I were talking earlier, and it's often very difficult for a general psychiatrist to work with older adults with dementia. So if you're lucky enough to have a geriatric psychiatrist or a advanced practice nurse who specializes in geriatrics, you may be in better luck, or geriatric psychiatry, you may be in better luck for that particular one, but oftentimes a general psychiatrist isn't very skilled in working with patients with dementia.
Yeah, I think that the 2/3 of you were responding to the stem of the question, which was what would you do first, or what would you suggest first? And I would agree that coaching is a good first step, especially since I think even in the face of hallucinations and possible paranoid ideation, this is a patient who is fearful, and if we can address the fear and the interaction with the daughter can be modified so the daughter is perceived as a helper, not an adversary, this may settle a lot of things down before you do have to go to trying a drug like quetiapine. However, if that doesn't really get the patient's distress under control, then it certainly is reasonable, again, to do a drug trial and watch for side effects and make sure that it's helping and not harming. That's really the principle behind any drug trial. And I agree with Pam that it's difficult to find a geriatric psychiatrist or even an advanced practice geropsych nurse in most communities in our country. We try to train more, but there aren't enough, so that is limiting. But I do think there are a small number of general psychiatrists who deal with older adults and have experience with dementia, but not the majority. So with that in mind, let's go on to the next question.
I wanted to mention one other thing that we had talked about earlier is that you have to set up realistic expectations for families that, you know, from day to day, your interventions may work and then they may not work the next day, but then work the following day. So you have to recognize that sometimes there's a little bit of trial and error, and don't be afraid to walk away as long as the individual is safe and come back and try something different the next time. So we're going to go on now to some resources that we've made available to you. We have a PDF that we will be sending you now that has a list of all of these resources for you. And the first set of resources are from the Alzheimer's Association. So they have the free learning workshops, they have Medical Alert or the Alzheimer's Association Safe Return bracelets, which are actually a national registry that you actually sign up or enroll in. There's a little fee associated with this. And you sign the person with dementia up to receive a bracelet or dog tags for this particular safe return. In the case that they were to get lost, there is a code and a 1-800 number that if they're found, the police can access this registry and be able to find out who this person is and where they live. So unfortunately, when people have dementia, they can develop delirium superimposed on dementia, and if they're lost and become delirious, they may not be able to tell you who they are or where they live. So this is critical when you're starting to care plan with the older adults. Not only are you going to do anticipatory guidance for end-of-life planning, but security and safety issues as well for them. So there's a helpline, a 24/7 helpline, and then there's also this really nice publication on how to respond when dementia causes unpredictable behaviors. And this you can have this available in your office, print it out, or just give them the website themselves, depending on how savvy they are. And then, you know, some of the classic books that are available for families that are taking care of loved ones with dementia include the 36-Hour Day. This is a classic. I can't even remember. It's 5th edition. It's probably even more than that now. Understanding Difficult Behaviors and some practical suggestions for coping with Alzheimer's disease is another one that's been particularly helpful. And then this is followed by What If It's Not Alzheimer's, a guide to dementia. So there are obviously many, many causes of memory and thinking problems, and everybody will say, oh, they have dementia and thank God they don't have Alzheimer's. But some of these other dementias can be very devastating to families as well. So this is a resource for them. And then we have government-sponsored resources, which are dementia care resources for the primary care providers. And the first one is the Alzheimer's Disease and Education and Referral Center. And the important thing to know here, if people are interested in getting involved in research or want their loved one involved in a clinical trial, this would be the place that you would refer them to, or you could go to identify a potential trial for them. And then the Area Agency on Aging, almost every community in the United States has their own Area Agency on Aging, and they offer supportive home and community-based services, particularly in-home care, adult day, and transportation is particularly a concern for many of these people. So that's a resource for you as well. So we'll be sending you, if we haven't already, a PDF of these, a list of these, so you'll have them for your offices and have these resources available. And then we just wanted to review a couple key takeaway points, and these are based on your objectives, that they're, behavioral disturbances in persons with dementia can be caused by many things, starting from medical conditions, somatic, and/or any need-driven behaviors. So remember to use that DICE method: describe, investigate, create, and then evaluate again to see if it actually works. And providing person-centered care, communication techniques, and addressing unmet needs are essential in addressing all of these behaviors. Validating the individual, meeting them where they are, trying to investigate what could potentially be causing these behaviors, and then trying to figure out what you can do to help them, and always offering to help them. Pharmacological management for behavioral disturbances has a limited role. Can be very helpful with distressing, or may be helpful with distressing psychotic symptoms. And then we are suggesting that you develop a portfolio of resources for persons with dementia and their caregivers for your practice. And we've given you some resources today to get you started in developing what hopefully will be helpful resources to your families and persons with dementia. And now we'd love to take some questions and see if we can provide you additional information. And so I think we may have.
So if you have a question, please use the questions section of the control panel for the GoToWebinar software. You could type it in and it'll send to me, and I'll forward to the presenters.
So one of the things, we have one question here about what if they're demanding the keys and want to go for a drive or get out of there, and they really want the keys and they're getting a little agitated. How would you approach that?
Usually we counsel families to help make the keys disappear, and then sometimes patients with dementia are still cognitively intact enough to want to go look for them, and that could be the start of an activity where you then distract them and find the cookies instead of the keys, and just change activities and change venues.
Right.
So there are lots of techniques that may help with that. I think the question about what about the keys raises a lot of larger questions about driving in general, and that's a conversation that I know, Pam, you and I both have early on with families when a diagnosis of dementia is made. It's important to help them plan ahead for the day when the person won't be able to drive anymore, which is tricky business. But alternative modes of transportation can be set up, and I think we have to be sensitive to the sense of loss of independence that many older adults feel when we tell them they can no longer drive.
Right.
But the keys themselves can be made to disappear and just be lost, if you will.
Right. So warning signs that it may be time to think about stopping driving are as if they start taking out the neighborhood mailboxes, they're having minor accidents, they've gotten lost, or say you know that they have peripheral neuropathy and difficulty sensing where their feet are in space. So those are some of the things that you can start to think about when addressing driving with the families.
Yeah, a question just came in about any of the medications for Alzheimer's disease, such as memantine, or I guess the cholinesterase inhibitors, help much at all with any of the behavioral symptoms. Actually, that has been looked at, and there are no studies that show benefit in terms of treating behaviors that are trouble. There are some studies that have suggested or have a trend toward the development of fewer behavioral problems for those who are on those memory drugs. But even there, we don't see really robust findings or statistically significant effects that have led to that being identified as a treatment in practice guidelines. There just isn't enough evidence to suggest that that's the way to go.
Do you typically stop cholinesterase inhibitors or memantine when they go into the nursing home? Because the studies really were developed to try and keep these persons with dementia in the community. I sometimes will keep them on it because family has asked me to, but when they start losing weight or have some of the adverse effects of the drug, I'll start tapering them off.
Yeah, well, I think we have to recognize, as you just said, that these are drugs that have, well, first, only limited benefit in terms of cognition. We're talking about, for cholinesterase inhibitors and memantine, only about a 4-point spread on the ADAS-Cog, which is the cognitive subscale that was used to get these drugs approved in the U.S. And the fact is that's not a very prominent improvement in cognitive function. But as I just said, these drugs don't really help the behaviors that we're talking about today, and so I don't think there's really a good argument for continuing them for prevention of behavioral problems. And given that they can have side effects, including vivid dreams, disruption of sleep in some cases, increased confusion in some patients who paradoxically get worse, and you mentioned appetite. Some of these drugs can, because they're procholinergic, cause nausea, churning bowels, diarrhea, loss of appetite. And when we see people losing weight, I usually take them off the drug. Or if they're complaining about scary dreams or disrupted sleep, I usually do a trial off. I don't see much virtue in continuing on, as these are not drugs that actually change the ultimate outcome. They've not been shown to help with prevention of behavior problems, nor do they change the underlying disease process in Alzheimer's or any of the other dementias.
Great. We have another question about, what if the patient has been using over-the-counter products that are worsening the problem? Say they're on Benadryl, for example, for sleep.
Yeah, I think that as we mentioned in the first half of this program today, antihistamines like diphenhydramine, or which is known under many labels, can actually cause paradoxical effects, increased confusion, as well as problems with in excess doses with actual increase in constipation and other side effects. So in general, we try to get people off those medications and come up with other strategies. We didn't have a vignette today on strategies for helping people sleep, but we did mention that part of sleep hygiene is trying to restrict daytime sleep and program activities that are pleasurable for the patient. And I think that if we keep people really active during the day, most caregivers come back and tell me that they're sleeping better at night.
Great. So we have a very important question, which we did discuss in preparing for this, is what do you do when a family calls that a patient at home with the family is becoming violent?
Yeah, well, I think I can't tell from that question about what we mean exactly by violence. I'd want to know more about what's the patient actually doing. Do they have a weapon? Are they terrorizing the place and tearing it up, or actually hurting people? But I think if we're in a situation like I just described, the other resource is to call 911. And I know it sometimes seems counterintuitive for families to call the police on your own family member, and it's not like these are people who are necessarily have a history of domestic violence, but we really have to think safety first. And the police are actually trained to respond to these kinds of calls. In many police districts, there is training on people with mental illness and dementia nowadays, and I think that they are first responders. I think once you have a situation where that kind of aggressive behavior or combative behavior is frequent and caregivers are getting hurt, that is a situation where it becomes important to get assistance from sometimes a psychiatrist or psychiatric nurse, or a psychiatric social worker who deals with geriatric patients and is experienced in dementia care. All of them can help with coming up with strategies for safety at home. Always safety first.
Right, and this should probably be part of the anticipatory guidance that you do over time with these families and persons with dementia, so that you have a plan if this were to happen. Unfortunately, it's not uncommon to have this issue come up with people with dementia. So, and then we have another question. Do you recommend a specific training or instruction for caregivers to focus on in order to establish a calming mood for the person experiencing ADHD, Alzheimer's disease related behaviors, I think is what they're talking about. Sorry, we were just having trouble reading our screen. So the Alzheimer's Association does have quite a few training sessions. Laura Gitlin has a whole program with occupational therapists and nurses that is available in some areas as well. But I think that any opportunity for ongoing training for family members is really helpful for them to enjoy. One of the things that has been coming to light quite a bit for with persons with dementia is a person-centered approach of music interventions for a calming environment. So that might be something to engage in as well. Do you have more to add?
Yeah, I think that in general, I routinely refer caregivers to make the connection to the local Alzheimer's Association, because they are resource rich. They run groups like this for both training and caregiver support, and there's an awful lot of help out there that I think it is good for caregivers. There are actually studies showing that when caregivers are supported, it can delay nursing home placement by anywhere from 6 to 18 months, which is not only a huge cost savings for the family, but it's quality of life points for the patient. So Alzheimer's Association resources that were listed on that slide, I encourage everybody to share those with patients and families. We have another question here about the main advantage. What's the main advantage of taking an interprofessional approach to managing behavior problems in these patients? Well, I think hopefully you can see from our the lecture and the case vignettes how many different factors can cause or contribute to the behavioral problems that occur, and how a lot of these have interacting effects. They interact with the cognitive deficits and with each other. So often we need a team to tease these things apart. And as I said, there are lots of people in the health professions. It's not just doctors and nurses like me or Pam, but it's the occupational therapists who often have some clever strategies for revising the home environment and making it less confusing, the social worker who figures out how to get more resources in there to get the caregiver some respite so that they're not overwhelmed, and holding the patient down to change their briefs because they're frantic and overwhelmed. I think that each of these professions has a particular role. We sometimes see the patients with arthritis who are pacing and getting their pain worse, need help from a physical therapist. So everybody has something to contribute.
Yeah. And thank you all very much.
I'd like to thank everybody for attending today's webinar.